Hello and welcome to another live stream of Dr. Barbara Miller's comprehensive NCLEX review. Today we're going to be talking about uh, mechanical ventilation. Okay, so why is mechanical ventilation required? There are many reasons for the patient to be placed on a mechanical ventilation. Okay, failure to oxygenate. Perhaps the patient has inadequate exchange of gases and the alveolar levels as seen in acute respiratory distress syndrome. It could be just failure to ventilate, decrease in mental status, or decrease by in compliance, or just let's say the patient has some long surgical procedure. It could be some type of transplantation. They want to rest the lung. Okay, so in any way, the nurse should know more about uh, mechanical ventilation, or the nursing student in the event that you're asked on your state board of nursing questions regarding the ventilation, more so the different settings. And we're going to be going over all that. Okay, so just let's get started. So you want to start with the ABC when you're rendering care to a patient on mechanical ventilation. So let's start with airway management. Remember, they're going to do the endotracheal tube. This can be placed orally or nasally. Okay, just remember, orally is the most common form of endotracheal tube, where the tube passes through the vocal cord. Remember, when patient has an endotracheal tube via mechanical ventilation, you must reposition the tube every 24 hours, or as per the hospital protocols. Okay, you want to monitor the patient's skin for any types of breakdown. Then you have your tracheostomy tube, the cuff or cuffless. You have two forms inserted below the vocal cord. And this is used for more of a long-term airway management. You want to maintain the cuff pressure. Don't forget that. You want to maintain the cuff pressure less than 20 millimeters of mercury. Okay, it is good to decrease risk of tracheal necrosis. That's tracheostomy tube. Another tube is the airway cuff. This assists with holding the airway in place, and it allows positive pressure ventilation with loss of tidal volume. What is tidal volume? Remember, we mentioned that is the rise and fall of the chest, or the inhalation of oxygen and the exhalation of carbon dioxide. Okay, this may reduce the risk of aspiration, oral and gastric secretions. If patient can talk or is losing the tidal volume, the cuff may not fully inflate it. You must know your ventilator settings. Know what's the tidal volume, rise and fall of the chest, or inhalation and exhalation. As mentioned, you got to know your PEEP. What is your PEEP? Positive and expiratory pressure. Okay, this is to prevent the closure of the alveoli, and it allows increased time for oxygen exchange. It could go high as 20 centimeters of water. So know that the PEEP is one of the hemodynamic monitoring that they utilize in the critical care unit, such as the ICU or CCU. Know your mode. The type of mode assist by the ventilator, the rate, the breath per minute adjusted basis on patient's own respiratory rate, your fraction of inspired oxygen, the amount of O2 being delivered. Got to know all these things to ensure that you're providing adequate care to your patients. So let's talk about the mode of ventilation. You have two. You have your controlled ventilation and your assist control. So what's the controlled ventilation? The vent initiate all breaths at a preset rate and the tidal volume. The vent will block any spontaneous breath. And this is used mainly in the operating room for patients who are sedated and paralyzed. Another form is the assist control. The vent will allow a patient to initiate a breath, and then the vent will deliver a preset tidal volume. Okay, so the machine is set at a minimum rate. So apnea, okay, when you stop breathing for a couple seconds, will not occur if the patient does not initiate a breath. So what are the disadvantages of these mode? Hyperventilation. If the patient has an increased respiratory rate, this can lead to respiratory alkalosis. It also can cause dysynchrony, where our breath stacking, the vent. You also have your BiPAP, bi-level airway pressure, okay? This is a non-invasive ventilation, okay? It delivers by mask, not airway. It's similar to the continuous positive airway pressure. What's the difference between the two? A BiPAP has two levels, and in contrast, a CPAP only has one. Okay, so this can be set at one pressure for inhalation and another for exhalation. I'm speaking on BiPAP. BiPAP and CPAP is utilized for sleep apnea, also used in patients with congestive heart failure and respiratory failure to avoid intubation. Okay, be mindful of that. BiPAP, you will deliver mask, not airway. It is so important for you to get familiarized with the different types of alarm system. The patient depend on you, okay, to be able to render the utmost care. So it would behoove you not to respond when the alarm system goes off. Okay, so you want to monitor your ventilator settings. Never turn off your ventilator setting, because you may run into big problems by doing so. For example, the patient is on the mechanical ventilator, the high pressure alarm goes off. It could be that the patient has secretions, a buildup of secretions. and you know that is frightening. Patient not able to speak readily unless you gave them something to write on, maybe a whiteboard to write on. Okay, so you need to know when that alarm goes off. It could be a buildup of secretions. Patient needs to be suctioned. And remember, you got to hyperoxygenate when you suction the patient. It could also be a kink in the tubing, okay? Malposition of the endotracheal tube. Patient may be biting the tubing or fighting the vent. Any of those factors could cause high pressure alarm to go off. It could be that water in the tubing. This is common for water to be in the tubing. Also, it's common for patient to have a buildup of secretion. If you were to ask what are the most common types of factors that causes high pressure alarm, okay, it could be bronchial spasm for the alarm to go off. It could be pneumothorax, collapse of the lungs, or decrease in compliance. For example, the patient has acute respiratory distress syndrome. That's your high pressure alarm. When that goes off, you need to respond. Then you have your low pressure alarm. The tubing could be disconnected from the vent. Okay, it could be a leak in the cuff or tubing, or it's extubated. The most common cause of uh, low pressure alarm, patient may have a leak. Then you have your apnea. Apnea is when the respiration ceases. If that alarm goes off, it indicates no spontaneous breath within a preset time. So general principle, the top priority, okay? Say you suspect that the tubing to the vent is disconnect, okay, or you're not able to find out or fix the problem while the alarm's going off. If you're not able to locate the problem and the patient now in distress, dire distress, you got to help the patient to survive. You want to turn the vent and bag the patient. You want to bag the patient with 100% of oxygen and call for help. Okay, if you're not able to solve what is going on, why the vent, the alarm system keeps going off. So what are the complications? They have several complications of the alarm or the mechanical ventilation that you must get familiarized with. Okay, so one complication is asynchrony or bucking. Okay, what is a bucking? There are two or more systems operate out of sync. They're not in sync. Okay, when something is not in sync, they become ineffective or inefficient. They're not working well as you would like. So that's one complication of mechanical ventilation. Another complication is that of auto positive end expiratory pressure. Okay, the PEEP. The PEEP is a hemodynamic Okay, so positive and expiratory pressure, PEEP, the patient does not expire full uh, tidal volume and air becomes trapped. This can cause increase in the alveolar damage. Okay, so PEEP is not working effectively. That's a major complication. Another complication of mechanical ventilation is that of a barotrauma. What's a barotrauma? Damage to the alveoli caused by an increased pressure and volume. Okay? And the other is nosocomial infection. Nosocomial infection can cause havoc on the patient who is on the mechanical ventilation. So hand washing is paramount. You got to wash your hands and before you render care to the patient. Other complications, patient could have anxiety, stress. The mechanical ventilation is a very frightening tool. You woke up and you find yourself on the mechanical ventilation. It could cause major stressors, which could affect their entire system, the respiratory, your cardiovascular, okay? It could also mess with the neuro. So it also cause one of the complications, sleep deprivation, because all the teams coming in to do their part to make you become well. So a patient may have insomnia. Patient also could develop ulcers, gastritis. Patient is malnourished. Okay, all those are factors that leads to major complications while your patient is on the mechanical ventilation. Patient muscles could get contractures. Okay, deconditioning. Why? Because patient perhaps may be on the vent for too long and they're not able to get that patient off. Okay, if they extubate, they may have to reintubate that patient. So the muscles become weakened. Patients start getting contractures due to deconditioning. Okay, and increase in the intrathoracic pressure, which leads to systemic edema due to decreased venous return. All that are major factors that could affect the patient. So to prevent complications, okay, you want to reposition the patient. Try your best to reposition the patient, to decrease risk factors of pneumonia. Also want to wash your hands. Hand hygiene is paramount. You want to elevate the head of the bed, okay, to expand the lungs more readily. And oral hygiene. You want to provide oral hygiene to the patient. Pneumothorax caused by high ventilation pressure. You want to auscultate the lung for lung sounds, okay? Or when you auscultate, you want to see if there's any adventitious sounds, abnormal sounds, and report that. You also want to consider sudden respiratory distress. Okay. Or if the patient may require immediate action of a chest tube. I do have one question if you want to answer. What is the most common cause of a low pressure alarm? You could put that in the chat line. And if the nurse cannot quickly resolve the issue causing the ventilator alarm, what did I say? What can you do to solve that problem? Okay. I'm getting better. Okay. I'm going to start incorporating questions and answers into the YouTube channel, at least 10 questions per video. So I'm home today. I'm going to work on that. And in future presentation, you will have more questions. Okay, so any questions you want to ask, please answer. What is the most common cause of low pressure alarm? And if the nurse unable to locate the problem while the alarm is going off, what would be the most top intervention that nurse should perform? Any questions? Any questions? So the answer to that would be what? A leak. A leak. And the second question would be, the patient, the nurse should bag the patient. Any questions? Okay, I'll see you tomorrow. I will speak on acid-base imbalance. Thank you for joining me. Hope this will be beneficial to your preparation for the State Board of Nursing examination. See you tomorrow with acid-base imbalance.